first speaker is Dr. Belinda Munroe. She's going to talk about a theory-informed toolkit for implementing a patient assessment framework into emergency nursing practice. Some of you might have been to another session that talks about this huge piece of work. I think this session will actually give you the knowledge you need to have to be able to implement it and use this document. Belinda currently works as a nurse consultant for the emergency departments across Illawarra and Shoalhaven in New South Wales. She completed her PhD in 2016. I think she might be another product of Kate Curtis. Yes. And her PhD was this work, so I suspect she's very attached to this. She also holds a peer-nominated board position with the College of Emergency Nursing of Australasia, and she's also a senior lecturer at Sydney Nursing School. Welcome, Belinda.
How do I change this? Is it just the green button? Yeah? Yep, okay. Thanks, Kylie, for that introduction. So before I begin, I'd just like to acknowledge the New South Wales Emergency Care Institute, the Agency of Clinical Innovation at the New South Wales Ministry of Health for funding this project, and also my co-authors who have also contributed a large amount of time and effort into this work, Professor Kate Curtis, Associate Professor Tom Buckley, Arinda Jones, Tracy Cootie, Kate Ruperto and Dr Lou Atkins. So we all know that patient assessment is important. It's fundamental to our nursing practice. As Dr Zeus said, unless someone like you cares a whole awful lot and assesses your patients properly, nothing is going to get better. So we need to assess our patients so that we can inform our decisions about treatment and prioritise our care. However, inadequate nursing assessment is a significant issue. It's a major contributor of preventable adverse events seen in the emergency department. And this has majorly contributed to issues such as the undifferentiated nature of patients who present to the ED, which makes assessment challenging, time pressures and the chaotic environment and workload in the emergency department. And we've also seen a rise in early career nurses working in the ED with minimal experience performing patient assessments and being able to identify the urgency of their needs. So it was interesting actually that patient assessment and frameworks was raised as one of the top priorities as part of the nurses research survey that's been going on, although I wonder whether that was one of my responses in there. So we know from the literature that a structured assessment improves clinical performance, and so HIRAID was devised, which is an assessment framework designed to provide emergency nurses with a structured approach to patient assessment post-triage. This was initially devised in 2009 by Professor Kate Curtis and colleagues, based on expert opinion and nursing theory. And later, when I took this project on in 2013, we refined this tool, informed by research evidence, and then tested it in a simulated setting. So if you're not familiar, this is what it looks like. It basically depicts the assessment process from when the patient first presents to the emergency department until they're discharged. There are 7 critical components. When the patient presents, the nurse must first collect a patient history, identify red flags, which are critical indicators of urgency, perform physical assessments, interventions and diagnostics, whilst continuing to reassess and communicate. It's a cyclic process which is ongoing until the patient is gone home or gone to the ward, and we may return to any of the components at any time during the assessment process. So this was the first validated approach that we were able to identify, published in the international literature, and this was a study that we published in the Journal of Clinical Nursing. And basically what we did was we evaluated the performance of emergency nurses in the simulated setting before and after undertaking a 4-hour education workshop in the HIRAID training, or in the application of HIRAID. And this demonstrated that the HIRAID approach improved the quality of nurses' assessment and also improved non-technical skills such as communication and decision making. So from this we knew that the approach worked, but we didn't know how to implement this successfully into practice. And so part of this study, at the same time, we interviewed and surveyed the participants of the study, which were 38 emergency nurses from 5 different hospitals across New South Wales, and with less than 3 years postgraduate experience. And we asked them what they thought about the tool. And so we did this immediately after undergoing the training, and then 4 to 6 months later we conducted some surveys, interviews and focus groups. From this we identified a number of facilitators and barriers. One, for an example of this, the nurses overall were quite satisfied with the tool and wanted to use it, but they found it difficult to remember all the components with that just short 4-hour education intervention. And so the aim now, or the next stage of the project, was to identify, well, how are we actually going to develop strategies or interventions to address these facilitators and barriers and successfully implement higher aid into the clinical setting. And hopefully you attended Lou's workshop or talk yesterday and you'll be familiar with the behaviour change wheel. But basically we followed a similar approach using three simple steps to select some interventions and develop some strategies and resources to be able to implement higher aid. We firstly attempted to understand the facilitators and barriers so that we knew what interventions we needed to develop. We then identified those interventions and selected and designed the resources. So the way we attempted to understand the facilitators and barriers, or the influences of behaviour, was by linking them with the different categories or influences of behaviour, using the COM-B model developed by Mickey et al. In 2011. So this model really comprises of 6 main components: psychological and physical capability, which is individuals' the mental processes that go into actually carrying out the behaviour. So the mental process required to use higher aid, their actual physical ability to have this, to actually use it in the clinical setting and perform the assessment. Motivation, so reflective motivation, so beliefs about the behaviour. Automatic mechanisms or that influence the behaviour, so like emotions and those unconscious intentions. And finally, opportunity, so the actual physical opportunity to conduct the behaviour and social interactions that influence that behaviour. So once we did this, we then used the behaviour change wheel to identify the different interventions that were most likely to be effective in addressing those influences of behaviour and getting nurses to actually use it in their practice. So using the behaviour change wheel, we identified intervention functions and policy categories, which I'll tell you about in a moment. And from this, we then had to identify which ones that the behaviour change wheel recommended were actually going to be feasible in the clinical setting. So this is the behaviour change wheel. If you're not familiar with it, you should become so, especially if you're involved in any practice change projects. So in the middle, you can see the COM-B model in the green, which are influences of behaviour. In the red, we have the intervention functions, which are basically group the different types of things or different ways that we can change behaviour. So for example, education is the use of information and knowledge. Persuasion is about communicating and using different sources, credible sources, to persuade people to use it in their behaviour. And then, so there are 7, how many interventions? Okay, I've got 9 interventions, and then 7 policy categories. You can tell me if I've counted incorrectly. So the policy categories are actually the decisions need to be made by authorities to actually carry out the interventions, and they're linked with the different types of interventions that are available to help deliver those. So, for example, to actually get nurses to use higher aid and document using higher aid, might create some sort of guideline to do that using regulation. or guidelines. So finally, once we had selected our interventions, we selected behaviour change techniques, which is also linked with the behaviour change wheel, which are actually the things that we need to use to actually change the behaviour. So while we're using so if we use education, what type of techniques are we going to use in that education, like feedback, instruction, and that type of thing. And so in the behaviour change taxonomy, which is lists nearly 100 different types of techniques, and these have all been grouped into what types of interventions they might be effective in being applied with. We then had to decide on, well, if we're going to use this type of intervention and these techniques, how are we actually going to do it? Are we going to do in-services or run education days or so forth? And finally, we needed to determine whether all of these things that we selected, even though it's recommended by theory, it's not a foolproof framework like most theoretical frameworks. We needed to use our brain and decide, well, is this actually going to be effective and feasible in the real world? And so we had a panel of expert emergency nurses and educators who sat down and reviewed all the techniques and things that we'd identified, and just then made a decision about what was going to be feasible. And then we developed the actual resources to carry out those interventions. Okay, so once we'd done this, we came up with a number of interventions, and this was from 5 of the 6 components of the combo model were actually identified to influence the behaviour of higher aid. So pretty much almost everything impacts on how nurses assess their patients. We needed to, for example, take into consideration the level of experience of the nurse, as this was identified to impact on how the nurse's actual ability to conduct a patient assessment. So some of the nurses identified as a junior nurse with minimal experience, it was quite easy to adopt the new approach of using higher aid. But they also identified, well, it might be a bit difficult for nurses that have been nursing for 20 years and were quite set in their ways. So the behaviour change wheel recognised this and that it fitted into the component of physical capability. So having identified those 5 components, we then linked them with the interventions and policies, and this found that we needed to use 6 interventions and 5 policy categories to effectively implement higher aid. And we also identified 16 behaviour change techniques that would be useful. So I'm not going to go through all of those because you really just want to get to the good stuff. So but I just thought I'd just give you one example of how we did that. We have, one of the barriers that we identified was the difficult to remember the higher aid components. Now this is keeping in mind that the nurses who reported this barrier only had 4 hours of education. And so training was identified as an intervention that was likely to be effective, and we thought that was quite feasible in the clinical setting and cost effective. So training is the imparting of skills. And so when we went to our behaviour change techniques taxonomy, it recommended using instruction, demonstration, behaviour practice and rehearsal, and feedback on behaviour. And you can see some of the modes of delivery that we then decided to use to carry out those techniques. And I'm going to talk specifically about those now in a moment. And just to provide you an example of the types of policy categories that were identified to assist in delivering those interventions. So I talked about before about the use of guidelines to help ensure that nurses used the framework to guide their documentation. We thought that came to the conclusion that integrating that into a policy would be useful to help inform that practice. So if you're really interested and you want to know exactly how we addressed every one of those barriers and facilitators, you can go and read that in the Journal of Clinical Nursing. And I just got this proof emailed to me yesterday, so it's nice to be able to put the proper proof up there. And so that's online at the moment. It's open access. So this is what we came up with. We developed a number of resources designed specifically targeting early career nurses starting in the emergency department, but we also kept in mind implementing a new practice. We needed to be using it collectively across our departments. And so we developed resources looking at the orientation of nurses, so integrating higher aid into the orientation model. We've developed an e-learning module and a full-day practical training workshop. We also identified from findings that we needed to have actual reinforcements in the clinical setting to sustain use and promote uptake in the workplace. So we've developed some documentation templates, which I'll show you, to guide the nurses' actual documentation, and some audits to provide feedback. We've got some lovely posters and reference cards, and a train the trainer or preceptor program that we've developed. So I'll just go through each of those in a bit more detail. 5 minutes, perfect. I might have time to show my video. So this is just a lovely picture of the orientation manual that we've got here at Wollongong. So this is given to our nurses when they start in the emergency department. And it's designed to introduce them to higher aid and the concepts, and provides them with the expectation of this is what we do in our departments. And so it integrates the different interventions of education and persuasion, addressing issues around lack of knowledge of the framework, beliefs about what it does, and hopefully promotes their memory of the higher components so they can refer to it. So what we've actually done within the book, we've introduced higher aid, but we've also provided some examples of common presentations to the emergency department and the types of things that you need to work through when doing your assessment. So it's a bit fuzzy, so you can't read it, but this is a shortness of breath scenario that we've put in there, because we all know shortness of breath is one of the common presentations that we see. And so it just talks you through, for history, the types of questions that you might ask for the different types of presentations you see, the types of red flags we should be alerted by, the physical assessments that we need to do, particularly having a focus on focused assessments, because we all know we need to do our A to G assessment, but what about actually doing a proper respiratory assessment, or what about feeling someone's abdominal pain, abdomen when they have abdominal pain? And so we also used behaviour change techniques such as instruction and credible sources, and by providing these, we plan to upload these on the intranet so they're available to staff, which uses the policy category of service delivery. So this is some snapshots of the e-learning module, which hopefully will be ready to go in the next week. So this integrates, again, education and training, providing instruction on what higher aid is, and we've got a case study integrated throughout the module, and a lovely video about how to communicate, which we've got our Director of Nursing starring in that. This is our practical training workshop that we developed. So at about the 3-month period, we've now got workshops set up so that our new nurses have to attend to actually have an opportunity to put into practice what they've learnt through the orientation and the e-learning module. And so we use simulation. You can see our cardiology CNC will be horrified that I've got his picture up there, but acting as our patient. And we also kind of have a bit of a communication workshop integrated into it, teaching things like greater assertiveness and reiterating how to use ISBAR in a relevant way in the emergency department. This is our documentation template that we've got uploaded onto EMR. So we have a number of different versions depending on what types of patient presentation is. We've got one for trauma and for mental health. So it just, again, is structured using the high rate approach. to ensure their documentation is done well, but also we've got a number of prompts integrated in there to help remind staff to go back and complete a proper assessment if they haven't already. We've also developed an audit, to provide feedback to staff if they're not doing this properly. Hopefully get them to do it. It's just some posters and some little, if you like your little reference cards, that we've made some nice ones of those as well. And we also developed a Train the Trainer program, which is kind of an abbreviated workshop for more senior staff to attend. One of the things we found, nurses felt like they didn't want to use high rate in the clinical setting because nobody else was, and we realised we needed to have senior staff modelling how to do it. And we found this is a really effective way of actually engaging in senior staff and getting them to use this structured approach without actually coming across as if we were teaching them how to assess patients when they've been assessing patients for 20 years. How am I going? Do I have time to show a short video? Yeah. All right. I've got a quick video. You can stop it, it's fine. So that was just a short video that we made engaging all of our directors of nursing across the district to demonstrate executive support, which was also one of the policy categories that we identified we needed. So finally, so we've showed that higher aid has the potential to improve emergency nursing practice, and we developed some resources to hopefully improve implementation. However, we still need to do some more further research and evaluate the implementation of higher aid in the clinical practice, and we've just got a grant from the Agency of Clinical Innovation to do that, and so hopefully next year we'll be out, or the year after, we might be able to present you with some results on that. Thank you.